Guys, should we start? Can you hear me?
Can hear you.
I get my I've got a I'm blurred, but not just my background. Anyway, you don't have to see my face.
It's beauty mode.
Beauty mode. I don't know, I need a ring flash or something, you know, to really highlight my shine. Anyway, that's what you're getting. Okay, cool. Guys, should we start? Is there enough people? I think there's enough, hey?
Yeah.
Cool. And
Yeah.
perfect. Let's do, so I've been asked to give you a couple of or to basically have a couple of cases. And I think what I'll do is I'll give you a very brief basic overview of the cartilage and the meniscal knowledge. And then after that, we can just go and dive into the cases. And I think the basics of cartilage and meniscus is just nice to kind of, when you get asked a question or when you have to write an exam, just to have something to kind of start with. And it gives you a nice overview of things, and almost like, let me just share this cases, meniscus basics. Okay, so I'll first want to share the screen with cartilage. These are the cases. Let's just see. So you can see this now. You can see this now. It means it says basic management principle of cartilage.
Yeah. Cartilage
Okay.
slide, yeah.
I'm going to start with this, and then we're going to go and do meniscus. It literally is like 5 or 10 minutes each, and then we're going to just discuss some of the more detailed stuff and with the cases. So we know this from, you know, when I had to learn, you know, or study for the intermediates. This is basically what they would always ask us. But it's quite important actually, because this determines quite a bit of how we treat cartilage injuries in the knee. And it is mainly the makeup of the cartilage that has got these three main zones: the superficial zone, the transitional zone, and then the deep zone. The superficial zone is mainly made of collagen fibers that have got a parallel orientation to accept shear forces. And then the transitional zone is mainly random fibers of collagen, and it's got quite a lot of proteoglycans. That means the proteoglycan is like a sponge to absorb water, or to hold water, and to organize water molecules, and to give it the property of shock absorption. And then in the deep zone, you have fibers that are orientated perpendicular to the bone to be able to anchor the cartilage. And a very important area there is the tide mark. And the tide mark is basically just the transition from calcified cartilage to non-calcified cartilage. And so it's almost, this tide mark is almost the barrier to an injury being deep or not. And it gives us a deep injury gives you a different healing response. And I'll get to that just now. So the characteristics of this cartilage, articular cartilage, is it basically gets all of its nutrition, or most of its nutrition, via the diffusion. So if the cartilage is unhealthy, or if it gets old, then this nutrient flow is less is poorer, and it has an effect on the cartilage viability, but also in its repair capacity. And it is basically very avascular, aneural, alymphatic, and the cells in the cartilage are quite lazy. They're quite big. They don't really communicate with each other, and so they don't like to repair, and they react very slow. And we know that the function is absorption and to decrease friction of the joints. So the main types of cartilage in the knee that are important to us are the articular cartilage, which is hyaline cartilage, and a healed cartilage, which is more fibrous. So when you look at these slices of histology on the right, the hyaline cartilage has got this massive layer of this second zone, or the intermediate zone, with a nice area for shock absorption, whereas the fibrous cartilage, you can see there's a lot more disorganized collagen in it, and fibroblasts, which don't have the same properties as the cartilage. So it's a compromise. Unfortunately, in South Africa, the fibrocartilage is really the only option for us to repair cartilage. One of the main options. Now, this is the way we classify chondral injuries. One is from the International Cartilage Research Society, the ICRS, and the other one is AutoBridge. Most of them, in most of them, it comes to basically whether it's deep or shallow, and whether the tide mark is involved or not. So when you have a grade 4 cartilage loss, it means a full thickness cartilage loss in the outer bridge, and it means in the ICRS, it actually means that there's also subchondral issues. So that means that not just the cartilage is involved, but also the subchondral bone, which affects the healing of a potential healing of the cartilage defect. And that's quite important when you decide on how to treat cartilage defects. So in essence, we, with all these small grading options, we basically try to group them into a deep and a superficial cartilage injury. Now, if you have a superficial cartilage injury, it doesn't cross the tide mark. There's no hematoma formation because the bone is not exposed. And the chondrocytes basically are not really able to establish a good response and cannot produce enough fibrocartilage, and it can't stick properly into the defect. So it just shears off. And so it's not an adequate cover, and it's a short-lived response to a defect. And it's just basically because the superficial layer is now injured, the shear forces are acting on the intermediate layer, which is not really made to accept shear forces. And that's why this cartilage injury becomes deeper and deeper. Now, with a deep injury, there's the penetration to or even through the subchondral bone, which causes a clot formation. And it does have a lot more fibroblasts that come and aggregate there and make a proper fibrocartilage scar. It's also not ideal for loading, and it does progress to local osteoarthritis, but it's still better than a superficial injury scar formation. Now, when you think about the workup of the cartilage, it's obviously important to understand what the cartilage, where the defect is, and how deep the defect is, and how big the defect is. But where we always fall into a trap is when we don't look outside the cartilage and we understand the loading of the limb. So it's important to understand what alignment this limb has, and if there's instability. And obviously with osteoarthritis, that means So the difference between a cartilage defect and osteoarthritis is, if you look at the cartilage as an organ, osteoarthritis is actually the entire organ is starting to become degenerate, whereas a cartilage injury is a local defect. And there's obviously a transition from a defect to the entire organ being involved. And sometimes that transition is not easy for us to put a finger on. But when arthritis is established, it means that the cartilage, not just in that defect, but in the entire joint, is affected. And it becomes a problem with healing. Even if you address a local defect, the healing response will be different, because the inflammatory response in the cartilage is different, because the entire joint has got arthritis or some form of inflammation. So if you have osteoarthritis in the joint, it's not ideal to treat cartilage defects. And we need to actually go to not repair, but more a reconstructive procedure. Most people base the algorithm of how to address these cartilage injuries on the lesion size. So less than 2 centimeters, between 2 and 4, and then more than 4 centimeters. In all these abbreviations we're going to go to now, but mainly what we know is microfracture and osteochondral autograft transfer, which is OAT. Now, in larger defects, the problem is that microfracture doesn't really work anymore, and OAT has the issue of donor side morbidity. So after trying to find cartilage from somewhere else, if that's more than 2 centimeters square, you have a problem with donor side morbidity. And that's why internationally we struggle to motivate for OAT or microfracture with larger defects, and they have got the ACI or the osteochondral allograft available, which we don't have. So for us, we really just work with microfracture and OAT, but it's nice to understand the concepts, as they might actually come to South Africa quite soon. And it's nice to understand it in case you need to write about it in your exam or say something about it. So microfracture is basically a stimulation of the bone marrow to produce blood that forms a blood clot and eventually forms fibrocartilage, like we mentioned initially. It's got an acceptable short-term outcome up to 5 years. And you can say about 2/3 of patients, or 3/4 of patients, are getting back to their previous level within those 3 to 5 years. But then afterwards, the failure increases quite quickly. We know it's mainly fibrocartilage, and unfortunately, we don't really understand the long-term benefit of it. But the nice thing is it's low cost, it's quite quick to do, and it's cheap. That's why it's the workhorse of cartilage defects. The osteochondral autograft transfer is also cheap, because you can, you have certain instruments that you can take a plug of cartilage and osteo and bone, and we plug it into some defect in the same sitting, in the same leg, and in the same knee. But you need to have perpendicular access to the cartilage to be able to take the plug out and put a plug in. So it's difficult to work in the posterior tibia, for example, or if you do it on the patella, you have to actually invert the patella. So it's a lot more invasive. The benefit of it is you're actually replacing cartilage with cartilage. So there's only a small rim of fibrocartilage around the OAT, but the OAT itself will act in a similar way than the original cartilage of the patient. So they return to sport quicker, about 6 months back to sport compared to 9 months with microfracture. And up to 10 years, between 8 and 10 years of time until it fails. So it's ideal for a young patient that is either living with makes his living with sport or with manual labor, that needs to return to their activity very quick and maintain the activity as long as they can. It's not ideal, or it's not recommended in patients that are older than 40. And obviously with the donor site mobility, if it's more than 2 to 3 centimeters squared, you run into trouble of trying to harvest a donor site. And it's not as good in females as it works in males. And it obviously works a lot better in the femur because you can access it better than the tibia. And the problem with the patellofemoral joint is the cartilage is very thick compared to the tibia. So it, or the femur where you harvest the cartilage, the thickness of the cartilage is a lot thinner than where you need to put it on, because the cartilage of the patella is about 1 centimeter thick. So there's a mismatch of cartilage, and that's why it doesn't work as well in the patella. And then there's ways to augment healing, and one of them is a matrix-induced chondrogenesis. And that basically means you do a microfracture and you put some form of a patch onto that defect, and that patch is supposed to absorb and to promote the clot that then turns into a fibrocartilage. And they're available to buy overseas. And some surgeons in South Africa actually just put a periosteum on the defect to allow the clots to form and not to wash away with synovial fluid. We're going to get to some of the results of those techniques in our discussion with the cases. So some of the details is taken out here. Then an autologous chondrocyte implantation means that, and this is another technique that one can use, and especially in bigger cartilage defects, is that you harvest a cartilage, you take those cells, you send it to a lab, and you then basically inject those cartilage cells back into the defect once they've grown. And at the moment, the outcomes are pretty much the long-term randomized controlled trials don't really show a huge amount of clinical benefit, but histologically there is differences between the cartilage formation in ACI compared to just a microfracture. And then these cells, they can also be put into a matrix, and then that matrix is a little bit easier to kind of put that matrix into a defect, so that matrix can be put onto a cartilage defect and has a similar property as the ACI, except the handling is a little bit easier. Now, with the ACI and MACI, the main thing is really that the quality of the cells is determined by the laboratory that grows it, and so they have to show certain quality markers like the cell count and such. But there's still quite a bit of variability between the different labs, and it's sometimes up to that process that makes it more successful than others. So it's very difficult to compare one study to another in this, because there is obviously such a big variety between the different labs that make these cells. A local option of this would be to have minced cartilage. So what you do is you scrape cartilage off, you mince it with the knife into small millimeter big sizes, and then millimeter sized bits, and then you take fibrin glue and you glue that into the defect. And so that is becoming more and more popular also in Europe, because it's obviously cheaper, and it turns out that it has a similar response and a similar histology as the ACI, except that you don't have this massive lab behind you. It's a single stage procedure. And there's quite a lot of research going into that at the moment. So, and kind of a very cost-effective option of this would be a minced cartilage. And then the allograft in South Africa, unfortunately, is irradiated, so it's got very poor property to load, and also the chondrocytes don't exist anymore, and it's basically not alive anymore, and that's why we don't really do allografts in South Africa. Overseas, what they do is they take an allograft, they put it into Ringer's lactate, they test the donor for diseases that are transferable, and then within a week you'd have to take this allograft and implant it into the recipient within about 10 to 14 days, because otherwise the cells die. So it's a process that's quite complicated to organize, because you have to have a donor that is willing to donate, and that is basically tested for disease, and then you have to have a recipient that is basically available to receive this within a week or so. And so that's why most of these successful operations are done in centers that are basically high volume centers specifically for this. The nice thing is that you can match the surface, you can match the cartilage thickness, and you can basically treat any size defect with it. But unfortunately, it's not available in South Africa for us. So this is the cartilage, the basic cartilage talk. Does anyone have questions to this? Maybe some of the people writing, if there's anything you want to know, or everything clear? Okay, so I'm just talking into my blank screen.
Prof, surely if you've taken someone's cartilage and then sort of randomly, haphazardly chopped it up with a blade and then shoved it back in, the cartilage has lost its whole structure that you spoke about, you know, all the specific layers and zones. It's just haphazardly sprinkled into the hole. How's that, you know, going to work out?
Yeah, it's a very good question. People don't understand it really. It's almost like a stem cell type process where these cells, they start morphing into cells that are a lot more active and start to create more cartilage. But no one knows exactly, and that's why it's so interesting, and that's why people are looking at it now, is why does bits and pieces of cartilage that are inserted into an area that is obviously physiologic. A healthy knee with a cartilage defect should have a physiological milieu. What do you call that? It basically should. The cartilage should have enough to grow and enough to morph into or heal, similar to what they would get in the cartilage cells would get in the lab. And so people basically in the lab would then add growth factors and would figure out the perfect pH for that healing response and the perfect temperature. And so when you mince cartilage and you put it into a knee that's healthy, it should actually have a response that creates growth factor and it with a microfracture underneath, and creates some bleeding and creates some has the perfect temperature and should have a similar healing response than in the lab. But people have no idea why this is better or not. In fact, we actually had someone that spoke to us, Prof Nera from Austria in our South African Orthopedic Congress last year, who's an expert in it. And he says he still tries to convince himself that it's better than microfracture. And it does look, on histology, it looks better than microfracture. But clinically, is not that much of a difference. So all of these things, the same with ACI, is there is histologically, there is the difference in the response. And it looks, and I've been in surgeries where they had a relook and looked at the cartilage after an ACI or after minced cartilage, it looks like healthy cartilage. It doesn't, it looks a little bit lighter, whiter than the cartilage around it, but it has a similar property when you go over it with the probe. But if that translates into long-term outcome, is still something that we don't understand. And that's why these techniques in South Africa aren't really yet promoted. That and because they're expensive. So we don't know. Short answer to a difficult question. Is there any more questions, or should we start with the meniscus? Let's do the meniscus. Let's see, I'm going to just do desktop. It's my house. Meniscus. Okay, cool. So, okay, I'm going to show you very quick meniscus, the anatomy of the meniscus. Just to remind us, this is the posterior horn of the two menisci, and the PCL is basically in the back, and about a centimeter anterior to the PCL is the posterior root of the lateral meniscus. So the kind of the sequence of attachment sites of the meniscus in the posterior part of the knee are the PCL, then the medial meniscus, and then the lateral meniscus. And the reason why I'm showing you this, it's quite important to understand where this root goes in case you see that there's a tear when you look into the knee with the arthroscope, and to figure out where that root goes and where it would normally sit. And if you want to repair it, you also need to find out where to put the tunnel. So posterior root, lateral meniscus, posterior root, medial meniscus, and then the PCL. And we know the lateral meniscus is quite C-shaped. It doesn't have an attachment, a fixed attachment to the tibia compared to the medial meniscus, which is connected into the meniscotibial fibers, and the MCL basically, and is very, very rigid around that the medial side. The lateral meniscus is a lot less fixed, and is therefore also a lot more mobile and can move and accepts a lot more rotational movement in the knee. And then in the front, so that's the important part about the roots. And then in the front, you can see the lateral meniscus is basically underlying the ACL. So it's just underneath the ACL, which drapes over the meniscus in a ribbon-shaped manner. And it's important when you think about ACL tunnel drills, and or for example, when you're trying to assess or shave the ACL off, you want to make sure that you don't damage the meniscus, and that relationship is important. And then also you can see that there's a meniscal intermeniscal ligament that comes from the medial to the lateral meniscus. It has some function and stability, but you can sacrifice it if you struggle to do surgery around the ACL. But it's nice to keep that structure because it does give it stability. The medial meniscus anterior horn actually inserts quite distal and almost doesn't insert on the tibial plateaus, but it almost just anterior to it, about a centimeter anterior to the ACL insertion. And that's obviously important when you do your entry point for the tibial nails. And the meniscus has got this perfusion. It happens mainly from the periphery, and then obviously the further you go to the inner third of the meniscus, the less perfusion you have and the less healing response you would get. And then with the fibers are the main fibers are orientated longitudinal and are anchored into the roots. And they accept the load transfer when you step on your when you step on your limb. The load is transferred through the meniscus, and those fibers are very, very important to keep the meniscus in the joint. So if those fibers are torn, the meniscus is pushed out of the joint. So that's why it's actually a lot worse to have a radial tear that tears those fibers this way compared to a longitudinal tear that kind of tears along the fibers. And that's why it's also more difficult for a radial tear to get a better outcome, and it's more difficult to repair it. We chatted about this. So fibroblasts are located mainly in the outer third, and the chondrocyte-like cells are in the inner third, and in the middle third and the inner third, these cells are becoming very small, flat cells with very little healing response. And the function of the meniscus is to absorb the shock and transmit load, but besides giving stability to the knee, one of the main things is to create congruency. The femur is round and the tibia is flat, and the meniscus basically makes it congruent and transfers the load evenly into the tibia. So when you step on the knee, the meniscus is pushed out of the joint, but the roots are keeping it in the joint. And that load transfer is basically called a hoop stress, or the hoop stress is counteracted by the meniscal roots. So what happens if the meniscus is pushed out of the joint is that patients don't only have pain that they would get with, for example, a horizontal tear or a longitudinal tear, but with radial tears or root tears, the meniscus is actually pushed out of the joint, and it creates contact pressure that is it's a point loading. And that means it's a high pressure with a low contact area, which means cartilage injury and later on osteoarthritis. And that's actually what we want to prevent with meniscal repair. You can see what is very light here is basically high contact pressure, and you can see how the larger area of contact in an intact lateral and medial meniscus changes with root avulsion or radial tear. And especially on the lateral meniscus, it's due to the shape of the condyle of the tibia, which is not concave but convex. That point loading is a lot more than on the medial side. So when we describe meniscal tears, we can describe them morphologically, and this is Freddie Fu and Hana that came up with this. It's just various types of meniscus damage, which is nice to communicate with someone if you see it on an MRI scan or doing an arthroscopy. And then basically some of the concepts are that the meniscal tear is often associated with an ACL tear, and more commonly the lateral meniscus is torn with an acute ACL tear. But in chronic tears, the medial meniscus becomes the primary constraint to anterior translation, and it starts to give you chronic tears with ACL deficient knee. And then the Donahue triad is the ACL MCL medial meniscus. It's just basically a histological, historical term, which, I mean, is nice to know, but I don't really see. I mean, everybody always talks about it, but I would say if you have an ACL tear and an MCL tear, you shouldn't just automatically say, well, this is most likely also got a medial meniscus tear, but it's usually also the lateral meniscus that can be torn because it could have been an acute injury. The management, and these are now grades that are proposed by larger associations of recommendation. The main thing is that the genitive meniscus tears in patients with osteoarthritis should be treated non-surgically. And that's obviously difficult when you start up in private, because you'll see a lot of these patients. And to send them away basically means you just send away income. But hopefully over time, people will see that, you know, the benefit to you is hopefully you'll establish in your practice, you'll establish a responsible management of these patients, so they come back actually when it's time for a knee replacement in 10 years, and avoid coming back for redebridements of meniscus, which I often see. The meniscus should be repaired, and there are better clinical outcomes with less severe degenerative changes in patients that don't have osteoarthritis and are young. And then what repair technique you use doesn't really matter as long as you do it well, and leads to similar outcomes. And the recommendation for these biological augmentation strategies, for example, PRP or putting in certain fibrin clots, hasn't shown yet to make a huge difference. And then also similar to the weight bearing and terminal flexion, most people limit that, but it doesn't have a huge grade of recommendation. So it obviously gives your meniscal repair protection, but it delays recovery of the patient. These are the three kind of main things how you can repair meniscus: inside out, all inside, or outside in. And the main thing that determines that is the location of the tear. So if it's in the back, so the posterior horn, it's the best way to do it is an all inside technique because it's fast. But you can also choose to do an inside out technique. You just have to protect the posterior neurovascular structures when you do it. But an outside in technique is difficult because it's difficult for you to come from the back of the knee and try to suture something. So the outside in techniques are better for the front of the meniscus, so the anterior part of the meniscus, where it's almost impossible to do an all inside suture or an outside in suture because of the placement of the devices that you've got available. And so this is here a way to do an outside in suture, and this is an all inside suture. I think we've done it at the cadaver workshops, and you know about this. There are more complex tears with different repair techniques, and the main thing is really the root tear, which the gold standard is to do a transtibial tunnel that basically takes the root with a sling of a suture and pushes the root onto the bone that you prepare beforehand to create some bleeding, and then you tie it over a button or a post on the tibia, on the anterior part of the tibia. So that's a root repair. And then a ramp lesion is basically a lesion of the medial meniscus, and the ramp is the capsule that's attached to the meniscus. So the meniscotibial fibers, if they are torn or if there's a discontinuity between those fibers and the meniscus, it's called a ramp lesion. And those ramp lesions are very difficult to see through an anteroportal arthroscopy because it's hidden underneath the meniscus. So you have to really see the posterior part of the medial compartment by pushing the scope into the posterior medial compartment, and also by opening up or pie crusting the MCL to really see underneath the meniscus to be able to see that ramp lesion. So that's a ramp lesion. And then there are more modern ways to repair radial tears, especially on the medial meniscus. Is also similar to a root tear. You do transtibial repairs, and you basically sling each of these limbs of the radial tear into the tunnel and basically push them together so that that the load can be accepted without tearing these small radial repairs. Postoperatively, the standard treatment is usually about 4 to 6 weeks of non-weight bearing or touch to weight bearing, with a decrease of range of motion or limiting the range of motion to avoid deep flexion. And that's mainly because you want to avoid hinging, basically squishing the posterior part of the meniscus and any repairs that you've done in flexion, and obviously making sure that the sutures that you placed are long enough are in the tissue long enough without tearing through the tissue, so the tissue can actually heal. Now, when these patients then go and transition through their rehab, they can't just after 6 weeks go and start playing sports again, because their quadriceps muscles are wasted, and they need time for the buildup of the muscle again and the coordination of the muscle contraction. And it takes quite a while to get that back. So it's usually a 9 months, 6 to 9 months period before they can go back to sport, depending on what type of sports they play. And that's it, guys. Enough monologue. Any questions here?
Hi, Michael. I have a question about the age cutoff for meniscal tears in someone without OA. How do you sort of approach that? If someone who's sort of older has sort of an acute injury?
Yeah, it's a good question. I also have a case on this, and we can chat about it in more detail when we talk about the case. But in essence, you don't actually want to treat patients with osteoarthritis. So if you see established osteoarthritis, talking about great, like pretty much bone-on-bone osteoarthritis, then you shouldn't actually do a scope. If you have a degenerative meniscus tear, then there's quite of a controversial guidelines, and I'm going to touch on that when we speak about the cases now. Most of them would tell you that age doesn't really make a huge difference when you treat them, but it is the symptoms. So when a patient comes to you and says, I've got locking and clicking that's painful, and they have got a degenerative meniscus tear, and it's affecting their lifestyle, most orthopedic associations give you a green light to debride that meniscus after a certain period of non-surgical management. And if that doesn't work, but if the patient comes to you and says, look here, I've got this dull pain at night after a long day, that's not something you can change by just taking out bits and pieces of meniscus. You're actually not making a difference to that patient's knee in the short term even. And with debriding meniscal tissue, you're not really making a huge difference in a long term at all. It's basically, you must tell the patient, my expectation for you is a short to medium term benefit if you have clicking or locking symptoms in your meniscal with your meniscus tear. Does it answer your question, Ashley?
Yes, thank you.
Okay, so obviously repairing a meniscus is a completely different thing, because the healing response is less and less the older you get. And so also the meniscus, the outcomes of meniscal repair becomes less and less successful. So the only time really when you really have to consider doing a meniscus repair is in a patient that without osteoarthritis or with minimal changes that has got a massive radial tear or a massive or a root avulsion, because this basically is a dysfunctional condition that pushes the meniscus out of the joint, creates joint loading, and you can really preserve a lot of the function by trying to repair the meniscus. And so most people, and even an older patient, would consider a repair of a root tear, even in an older patient. Let me go to some of these cases, and we'll just go and see. I'm going to just take some of these people that I see here. I don't know who's writing next. Who are the guys? Let's see who's here. let's just go from can't see now. Who's writing?
I'm writing next. It's Kim.
Okay, Kim, what do you see?
Hi, Prof. I'm looking at an MRI of a 18-year-old patient. It looks to me possibly like the double PCL sign, which may indicate a bucket handle type meniscus injury that would require treatment.
So that's right. You see it. This is the
Double
posterior
PCL.
primary, and this is the meniscus that's flipped into the notch, and that's why you can see it there. And that's it's a good point. Tell me, what are the most sensitive clinical signs now when you test this meniscus for this patient for meniscus tear? You haven't seen MRI scan. What is the most sensitive meniscus sign that you know?
Well, I think first I'd ask about the history, if there's any locking or clicking, and ask them exactly where the location is of the pain, if it's along the joint line.
Okay.
And then, sorry, Prof?
Yeah.
I'd ask them if the location of the pain is along the joint line, and then you could do a grind test using their own body weight. I think that is, for me, the most sensitive when you get them to stand, although it is not specific.
What's the test called?
The Apley's grind test, if I'm not mistaken.
The Apley's grind test is a good test, but it's not the one that when they stand on the leg. So the one when they stand on the leg is called the Thessaly test. The Apley's grind
sorry,
test
yes.
is what you do. So the difference between the two tests is that in the one you
Sorry,
cause pain, and in the other one, patients causing the pain to themselves, and they can stop it when they feel too much pain. And that's why it's quite a nice, elegant way in an exam to test for meniscus tears. Okay. So you are right. I'm going to show you the sensitivities, which is interesting, that joint line tenderness is actually most sensitive out of all these tests. Also, it's quite difficult to find the correct way to do these tests because there's so many variations of it. But in the end, most of them will have some form of rotation, flexion, and then varus or valgus in them. And positivity or positive test means it's painful or it's clicking or locking. So actually, if you have a joint line tenderness in a patient, you don't have to do more tests because you're just giving more pain to the patient. And the joint line tenderness is actually the most sensitive one. That's what I want to try to say with this slide is you can obviously do all these tests if you're unsure, but if you have joint line tenderness in an exam, then you don't have to go further because you're already determined that there's pain, and you don't need to now figure out if there's locking. An MRI scan is, we can describe these signals here, and sometimes you see a signal in the meniscus that can potentially mean some chronicity, but it doesn't communicate with the actual joint fluid. So what you can see here is a grade 3 signal, and that's what you're looking for to determine that if there's a meniscus tear. These other signals are described, but they're not necessarily a tear. So you would only want to really go and look for meniscus tear and suture meniscus tear if there is a grade 3 signal. That means it's connected to the fluid signal. And the MRI scan is obviously the gold standard to determine a meniscus tear because it's very sensitive and specific. A little bit more so for the medial meniscus than the lateral meniscus, but I mean, they're both around 90% sensitive and specific. Okay, cool, Kim. So that's a bucket-handled meniscus. What would you do surgically?
Sorry, Prof. I was muted. I would assess the tear during arthroscopy, and depending on where the tear is, or the location of the tear, I would plan to do a repair in that young patient.
Okay, so what do you think this? What do you mean by that location? Do you think this is it is? Would you repair this meniscus? This one here? So the
Yes,
answer is
I would repair it. Yes.
yeah. You want to try to give everything to repair this meniscus, because if you cut it out, then an 18-year-old athlete will not play for long anymore and will probably get arthritis early. So you try to repair that meniscus, and it takes quite a bit of time and effort to repair a meniscus, but it's almost like the best tissue. If you cut it out and it's more than half of the meniscus, then ideally that patient should have an allograft, which we don't have available. And so any tissue that you can find in the knee that looks like meniscus is still better than allograft or nothing in our case, because it's a chance. And if it fails, you can still cut it out at a later stage. But yes, you want to repair this meniscus. Okay, thanks, Kim. Next one.
Thanks, Prof.
Who else is keen? Next one.
I'll go.
Who's that? Ahmad.
Yeah.
Okay, Ahmad, this is your case.
Yeah, so the 67-year-old active patient presents with joint line tenderness and intermediate effusions, no locking with the following X-ray. She wants a pain.
Yeah, there's just a whole bunch of pressure on me here. This is a real case. So this is from the hospital manager. They say they've already written 2 emails and they've given me the relevant documentation and they want me to now sort it out. This is from our colleague. She's saying this patient's got diabetes, hypertension, and has got cholesterol, but the MRI shows clear tear. She's still dancing, and this is the X-rays that you can see here.
Yeah, so I'm assuming that's a weight-bearing X-ray.
Yeah.
So on this sort of blurry picture, there is some evidence of early osteoarthritis with the joint line or joint space narrowing on the medial side, with evidence of subchondral sclerosis. I can't really make out if there's any cysts. She doesn't have any gross malalignment of the knee itself. And on that images from your arthroscopy, we can see some fraying of the meniscus and commented on the MRI. So I think evidence does show some advantage in the treat or in debridement and arthroscopy in early OA in active patients who aren't obese. So I think in her, it will benefit her to
Which
debride.
evidence do you quote here, Ahmad? And this is the question that you will be asked now, because this is obviously a very hot topic, and you'll have to really stand your ground for or against, not just in the exam, but literally in front of the patient. And now here, this is in front of the hospital manager. So I had to really say to them, look here, this is, by the way, not the, and we didn't scope this patient.
Okay, yeah, but if that is, that's how it looks.
That's how it would look like, yeah.
Yeah. So I mean, I don't know specifically, but just from reading, I think if I was, maybe I should I don't know.
What is you have to come with level 1 evidence, or with high, with.
Can I just say JBJS?
Not just Dr. Held told me.
I'll say JBJS. There's an article there somewhere.
Okay, yeah, let me give you one. So this is against the treatment of degenerative meniscus tears. This was a study in the New England Journal of Medicine. It was published 10 years ago, and it was a Scandinavian study, which is the Fidelity group of Finnish degenerative meniscal lesion group. And what they've done is sham surgery. So they had 2 groups. The one, they just did an incision and they closed it up again, and the other group, they did an incision debrided the meniscus and then closed up again. And then on the right here, you see that the various knee scores of both groups, and you can see that they're almost the same at baseline, at 2 months, at 6 months, at 12 months. So maybe in the pain, there's a little bit of a change initially, but at 12 months, it's pretty much the same. So this was a well-powered, study to look at that. And obviously broke a lot of surgeons' hearts, because it is basically the most commonly performed orthopedic procedure in the world is meniscal debridement. It's like the bread and butter, and then these people are telling us we can't do it. And that's why we came up, there's another randomized controlled trial that was published in the BMJ in 2016, which says there's a strong recommendation against the use of arthroscopy in nearly all patients. The recommendation applies to patients with or without imaging evidence of osteoarthritis or mechanical symptoms. So they even say, don't worry about the mechanical symptoms. It just doesn't make a difference. They know that it's the most common orthopedic procedure, and they find that arthroscopy is not better than any exercise. So that's the randomized controlled trials, specifically randomized controlled trials. And then the people came together, the orthopedic surgeons of the various orthopedic associations came together to give recommendations. And you can see here what most of these societies recommend patients with mechanical symptoms to have debridement. So if you say that in an exam or to your patient, you say to them, look here, let's try for 3 to 6 months and treat you conservatively. If you come back to me and you have clicking or locking in the knee, and we've got evidence of a big flap tear, then let's do the debridement. Because I'm treating you based on the recommendations of these societies. But you can also tell them, look here, it's not going to make a difference to you based on these randomized controlled trials. And then you've told them everything you need to, and then you can decide with the patient what you want to do. So that's actually the best way to treat degenerative meniscus tears. Okay. Any questions?
So she has, that MRI does show that she's got some.
Yeah, she's got degenerative meniscus tears on the medial and the lateral side.
Yeah.
She's got early arthritis. So in a setting where I have limited access to theater, I can't treat these patients. So I actually can't, I even try to block them to come into my clinic. And that's why I get these, that's why I get these harsh emails always, because they're obviously in pain and they think that it's important for you to debride the meniscus because it'll give them a better knee, but it actually doesn't really give them, there's no evidence that shows that will make a huge difference. Okay, next one.
Sorry, Michael, it's Peter. But what's your options for that patient now? She's 67, she's in daily pain. I mean, they're just going to take that many analgesics and try physio a few times and then...
Yeah, you tell me, Peter. That's a good question. That would be my next question to you.
So, I mean, as part of your conservative treatment, it obviously will be muscle strengthening and stretches and analgesia and everything else. But I mean, it's also it's finite. They're going to get to a point where they can't handle that anymore, and they're not nearly there for a knee replacement yet.
Yeah, right.
And they're kind of in limbo. You're trying to stretch them up to the point where it will be feasible to do a knee replacement. But I mean, in the interim, you're very limited.
Yeah. So what would you do?
You have to.
So it depends on if you're in private practice and you want to keep that patient, or if you are in state practice and you're just trying to keep a clinic lean and clean.
Yeah, I suppose so. Then if you do have access to theatre, there is evidence to support taking for arthroscopic debridement and
You're
I
right.
suppose.
Evidence is a recommendation. There's no real evidence, but there's a recommendation that we can do that.
Recommendation
If she
to
has
support it,
locking
yeah.
and clicking symptoms.
Yeah.
If she doesn't have locking and clicking symptoms, it shouldn't be a recommendation.
There's not much that you can do, yeah.
No, because all you're going to have is an unhappy patient that you've operated on. In your last touch, you're going to have that patient in your clinic coming back to you, telling you how unhappy they are. Taking out bits and pieces of cartilage doesn't mean that you make them better. So what you can do is, remember the initial thing on cartilage is you can look at the axis. You can potentially adjust the alignment. If the alignment is favorable for an osteotomy, and if it's a good patient for that, that's a different discussion, but that would be an option for that patient.
But for a 67-year-old.
Or 67, that would be very old already. So what people do now in private is they do MRI scans, and then they look for bone bruising, and then they say that that's an indication to do partial knee replacements. Although, it's a very kind of white collar approach, and then you have all the other things, the in-betweeners, the PRP injections, the hyaluronic acid injections, the cortisone injections, stem cell injections, and that's all industry driven. So there's no clear evidence yet. There are some small reports here and there and some meta-analyses that show that it's equal, cortisone injection is equal to PRP injection, but none of them show long-term benefit. And basically in private, the mentality of the patient is, it can't hurt, so let me try. And then what you do is you have this whole injection business as a side hustle, and you try to keep the patients until they're ready for their joint replacement. But
Well, they get a septic arthritis.
Exactly. In essence, it just depends on how you want to run your practice. In the end, you try to find a good patient for a good surgery, and that's not that match doesn't exist here. That is basically a patient you have to be hard with and say, look here, I cannot help you with surgery right now.
And then on a X-rays, is there no? Well, she's got some features of OA on that anterior or on that medial side.
Yes.
Would you not then potentially recommend for a unicompartmental?
Yeah, what's the benefit, or what's the indication for that? What do you need to do a unicompartmental replacement?
Well, so she can't be have an inflammatory cause with arthritis. She needs intact ACL, PCL, and no tricompartmental. Well,
that's right.
OA.
That's right.
And collateral and intact collateral ligaments.
And the main thing is you need bone-on-bone arthritis.
And bone-on-bone, yeah.
So I mean, you could argue in her that might be bone-on-bone. It's a little bit fuzzy, and I think this is maybe just a patient from the internet. But if that's bone-on-bone arthritis, then definitely this is a case for a unicompartmental knee arthritis if the patient has failed conservative management. But if you don't have bone-on-bone arthritis here on this X-ray or on any Rosenberg X-rays, then it shouldn't be you should not default to become a to do a unicompartment knee arthroplasty, because your outcome is not predictable. So you need bone-on-bone arthritis for any arthroplasty to really have predictable outcomes. Okay, let's go to the next case, but at least we're discussing this nicely. Have a look at this. Who's next? Guys or ladies? Is Peter, are you writing?
Which one? We're both writing.
Well, then Peter that is speaking now, and then the next one is the Peter that's quiet.
Okay.
So Fenter.
Okay, so this is history has shown 1 month post injury, 3 cuts of an MRI. It shows medial compartmental distal femoral condyle edema, as it's indicated there. Its pictures are quite small. There's a go sign at the back, which does mean avulsion
Avulsion
of the meniscus, the posteromedial. And then looking at the axial cut, see there's also something is plotted out there, but you can see there's a hyper intensity in the posteromedial corner
so what you're looking at,
so that's the ligament you just said on the Charlie Brown video. I can't remember now.
I can't tell you now. I wanted to take this thing away here, but I can't now. But this says meniscal root tear.
Yes, the root.
The root of the meniscus is torn here. That's why the meniscus is pushed outside the joint. That's why you get all this edema here, because he's walking, he's point loading, and that's why you can't see a meniscus root in this. So it's very difficult to actually, on MRI scan, to really put your finger on a meniscal root tear, because it's literally just one slice, and if that slice doesn't go through the meniscal root, then you can't really diagnose it. So the meniscal extrusion and these edema, these indirect signs are actually quite important to suspect it. The main thing is really to have the equipment that you need in theater. If you are looking at a meniscus root tear, you need special equipment in theater to be able to do what is the gold standard repair for this?
That would be you need to reattach the root. That would be arthroscopy with anchors, I would say.
So the gold standard is a trans-tibial tunnel root tie. So it goes, you tie the root, you sling a suture around the root, and you put it through a tunnel so that you can pull the root onto the tibia. Because when you use anchors or fast fix devices, all inside devices, you actually don't tie it onto the bone, you tie it onto the capsule. And so you can't ever really place it where it's supposed to be. Okay, so this is the effect. So basically, this is an intact meniscus, and we saw that before, and this is a dysfunctioned meniscus, and this is basically this was a cadaver study that showed that if you repair the root and you repair it in the right place, you can have a near normal biomechanical function again of the meniscus, which is massive in terms of preventing arthritis. Trying to see. So these are just, okay, if you would have told me, okay, well, we have to debride this, then these are some of the studies that you can mention. We don't have to know this by heart, but just figure, to say that a repair has a higher reoperation rate, because obviously it can fail compared to a meniscectomy, but it's got much better long-term outcome. That's a meta-analysis done. If a tear is not repairable, you shouldn't do a total meniscectomy or a subtotal meniscectomy. You should just take out the bits and pieces of torn meniscus and leave as much tissue as you can, because it is still better than not having anything. The repair is a massive failure rate, actually, depending on how old the patient is and what the repair type is, up to 40%. So if you are speaking to someone with a meniscal tear, you mustn't promise them that you're going to make them 100% better. There's actually a 15 to 40% failure rate. But if you are repairing them and it fails, you're still debriding less meniscus. So 80% of the cases, the second operation, you would debride less than you would have done in the first operation. And that's why people are trying to say, look here, if I'm in doubt, let me rather err towards repairing the meniscus, even if I have to come back and just do a smaller procedure than I would have done initially. And most of them then are symptom-free after the second revision. Okay, so we spoke about the treatment, right? These roots in the back, and this is basically how it's, how you would do a root revision. This is the root, it's torn off. It's actually a chronic case. It's going to take a while to see the next slide, I think. Oh, you curate the bed of where the root needs to go, so you can take out some of the scar tissue and also some of the cartilage. So you take that off with a curette, and then you place a tunnel aimer, and you basically drill through that, and then you tie a suture tape or a suture around the meniscus root, and then you pull it into the tunnel and onto the bone, so it's back there, and you can see how the meniscus, by doing that, how that meniscus is pulled back into the joint. Okay, so that's you just tie it over. Okay, let's see. Okay, postoperative management. I'm not gonna. We basically said that, hey, 90 degrees. So you're trying to avoid deep flexion and some weight bearing. Cool, Peter. Peter,
Michael, just so if is it the same treatment for acute? Obviously, if it's an acute versus
yeah, it's the same. Yeah,
the same thing. It's not going to be.
You don't want to leave a root tear, because it is basically, if you see a root tear and you leave it, it's as if you would have taken out the meniscus, because every time this patient,
it's not there.
It's pushed out of the joint. It doesn't actually have a function.
Okay. So it's better to fix it as soon as possible, obviously.
Yeah. So that's the difference between a horizontal tear or a vertical tear and a radial tear. A big radial tear, you know, if the radial tear is more than 50%, or if the root is torn, it means that this meniscus is completely dysfunctioned. Okay, Peter Buerter. Are you guys happy with the speed here, or must I go a bit quicker? Because, I mean, we can talk. I've got lots of, I just want to make sure we can keep in time. I don't want to overdo this. What time is it now? It's 9:15. So we've got at least another 15, 20 minutes. Okay, Peter Buerter.
Prof.
Okay, how are you? Peter, you sent me an email a couple of weeks ago to say that you wanted to have case-based discussions.
100%.
Is this what you want, Peter? I'm just doing this for you guys.
Thanks, Prof.
Okay, good. It's quite a lot of effort here. I hope you appreciate it, Peter. For you.
Thanks, Prof.
No problem. So this is your case. Is this better with an ACL recon or not?
So, presented with this arthroscopic view is what appears like is the intercondylar notch, and see the condyle and ACL ligament itself. And then
what is this guy doing here?
I mean, he's going to. It seems like he's going to do it. He's about to plan for an ACL recon.
But this is too small for an ACL drill. And it looks like
it's probably. I mean, he's microfracturing certain something.
Why is he doing a microfracture and a notch?
I mean, he's creating bone marrow stimulation. I think he's expecting that good biological response with new mesenchymal stem cells, etc., and all the good properties with the bone marrow. I mean, that's what the clearance you can see on the far right. That's the fat and the bone marrow on the right.
Yeah, perfect.
So I guess. Is that what he's trying to do? Is this question is whether that microfracturing assists with an ACL reconstruction? I guess that's the type of question you're asking.
Yeah, this is a biological enhancement of healing. So you can, what else can you do to enhance healing?
I wouldn't say like any form of biological patch, but that's
what is a biological patch? What can you do?
You can. I'm not entirely sure, but it's also similar to like chondrocyte implantation, where you just put chondrocytes or some patch over the ACL in a way, or close to it.
Yeah. So we're still talking about meniscus, by the way. So you've got a meniscus tear, and you're just trying to enhance its healing. So you can do this kind of notchplasty or notch drilling, and then you could have a fibrin clot that you create with the patient's own blood, and you spin it in a glass, and then you create a fibrin clot, and then you can put that into the meniscal repair, or you can inject PRP in it. And there's all of these are expensive techniques and time-intensive techniques, but an easy technique is what you're doing here. So obviously, if if you do an ACL reconstruction, it's better healing because there's inherently some bleeding in the joint that creates some form of or attracts some growth factors. Okay, Peter, this is a patient now here. Yeah.
There's a question there because I mean we spoke about PRPs earlier. Is there any role for like mesenchymal stem cells injections or like hyaluronic acid, and I think I don't know what the other one is, but any role for that in the meniscus repairs?
So the meniscus hyaluronic acid is more used for cartilage wear, although without any high-level evidence. And meniscal enhancement for meniscal healing are, like you say, there are options of injecting stem cells, although that's in the experimental phase still. So many people are trying to do this stuff, but we don't really know yet what the healing response is to PRP even. There certainly is quite a lot of inflammation around meniscal repairs, so you have to wait for the PRP injection. You can't do it right away. But I know Steve does it in the shoulder to enhance healing of the rotator cuff, but it's not as much done in the meniscus tears, and certainly not the stem cell therapies. That's literally very early in the. It's not a mainstream technique. I want to show you this, Peter, and this is something very difficult in our setting to treat, and so I want to ask you what you would recommend to this patient if he had any possibility to fly anywhere in the world.
I mean, you've partially done a partial meniscectomy on lateral meniscus there, so you've taken his shock absorbing cushioning effect, creating a high contact pressure.
He's left a small little peripheral rim, and there's obviously some anterior and some posterior horn, but he's taken out a big chunk of the meniscus here.
Yeah. I mean, as the patient's young, active, so I suppose what you've taken out, you want to try replace with some form of like autograft or allograft in terms of reconstruction. I just don't know what kind of biological soft tissue interposition maybe you can put in between that. I'm not too sure.
Okay, have you heard of anything? So obviously allograft is an option, but what is mainly, when are we using allograft? Meniscal transplants, basically. When do you use that? So it's mainly in a patient that has almost like a subtotal meniscectomy done. And in those patients, it's very difficult to use a patch. But this patient here has got a good rim, and therefore some people would argue that you should create some form of, or have some form of patch available for him. And I'm going to show you these patches just now, and then the transplant, and I'll show you how the transplant works just a bit later on. It's a bigger surgery than these patches. So these are the two patches really that are available at the moment in Europe, and one of them is called the CMI, and the other one is called the ActiFit. And they've got different properties. The one is a bovine, so the CMI is a bovine Achilles tendon with many collagen 1, and both of them require a good rim to attach it to, and good posterior and anterior horns, because you just kind of patch it, but you can't. This meniscus doesn't have the same properties as a transplant, so it can't anchor into the bone. It has to actually be sutured into meniscal tissue. So if you don't have a rim to suture to it, you can't use it. And this there's a big fight between these two companies, and so the ActiveFit doesn't want CMI to come to the States, so it's only available in Europe. And this ActiveFit is a polyurethane, and it basically is almost just like a way for the collagen to grow into, and for the cells to kind of find their feet in that collagen, in those urethane template, and then kind of create some meniscus like structure in there. But it's just to basically buy yourself 3 to 5 years, and then after that, usually you have to debride it. Right now, there's quite a lot of research into printing meniscus tissue you can even print cells into the meniscal tissue, and you'll soon be able to actually have a viable tissue with living cells that you can print and insert, but that's also still just in the lab. And this is how an allograft works in the lateral side, and on the medial side, it's a little bit more tricky because the meniscus roots are so close together on the lateral side to have to integrate into the bone. And in South Africa, there's really just a few people that are doing it. So Hayden Hobbs has done a few, and then Willem van der Merwe. And what they do actually is they bring in blocks of fresh cadaver, which is quite a huge mission, financially and also organizationally, to get here. And then it doesn't come pre-cut like this. They actually have to shape in the roots, and they have to hopefully have the right size match. And then you basically have to suture that meniscus into the capsule and attach it with transosseous tunnels. So it's quite a mission to do that. So that's why I'm saying, if you can somehow repair a bucket handle, rather do that than try to figure out ways with a meniscal transplant. Many people, if you have a patient and in South Africa it's difficult to get this tissue, they are actually flying to India now to have this done, because surgeons there have got a good experience with high volumes and actually good allograft. And obviously, besides that, another option is to go to Europe or the States. Yeah, so these are the two ways. And here are just this is just some studies or some evidence around these scaffolds, meniscus scaffolds. There's just very few independent studies. Most of them are industry, financed through the industry. And they are similar than the transplants, but obviously the transplants are usually done in patients with a lot more meniscal tissue missing. And these are the meniscal autograft, allograft outcomes. And this guy for Donk is actually a Belgium that has got quite a lot of experience in it. And I think he's retired by now, but he's done a lot of work on meniscal transplants. And obviously, in someone that does that quite regularly, the outcomes can be quite good. So there's 80% long-term survival rate in this, and you can improve the pain. You can improve your patient-reported outcome scores. But it's really only a solution for the younger patient that has got a stable knee without osteochondral or arthritis in the knee. And so you have to get this patient quite early. If the patient is without a meniscus for a while, he starts to have a degenerative joint very quickly, and then it's unfortunately not a good option anymore to do a meniscal transplant. Okay, cool. Peter, just very quickly, since I've been doing more talking than you, just have a look at this. Oh, sorry, is there any questions on meniscal transplants or, meniscal patches? No. Okay, good. Peter? You still awake?
Yep.
Okay, so this is another patient now. You've done this. You're doing this arthroscopy right now. You've passed your exam. You started private practice, and this is your first scope. When you're looking at this, just tell me what you see and what you would do now. It's a 30-year-old patient.
So, yeah, young patients notice in lateral femoral condyle significance. I can't really exactly know what the size is, but an osteochondral defect or lesion. That's yeah, it seems that it goes possibly to the subchondral bone depth, but noticeable, as I said, is a significant osteochondral defect, particularly in the weight bearing, seemingly on the weight bearing part of the joint.
How would you grade it?
That's we talked about the outer bridge earlier, but that was more for OA. There's the grading. I think it's an ankles. There's a Burton Hartley classification as well.
This is the knee.
So whether so you get MRI classification and arthroscopic, and then it's.
But this
one
is
is where.
This is an arthroscopy.
So based, I guess, would be size in terms of it.
Okay,
and then
what is the size kind of that you have in mind that is important, the kind of the cutoffs?
About 2 to 2, less than 2, and then obviously particularly greater than
exactly.
2.
So it's, so depending between 2 and 4, that's like kind of, you can still work with 2 to 3 centimeters squared. You can still work with our local kind of tools, and then more than that is a problem for us. And so that's that's the size, and what is important besides the size, and why?
Well, exposure of subchondral bone, and then
Yes. Okay, so it's down to bone, right? So it's a grade 4 ICRS for water bridge.
Water bridge, yeah, I guess those 2.
Okay, cool. So, and then you obviously want to now figure out a few things. So what's your surgical options that you have here?
So, I mean, you've got to look at the patient's radiological features. So you also got to look at, I mean, the hip, the alignments, mechanical alignments, particularly of the knee. So, I mean, if he's in various valgus deformity, can you offload that particular, I think that's defect, which I don't think you can in this particular situation.
Yeah, so that will affect the outcome. Yeah, so radiologically, the alignment would affect the outcome. What else?
And yes, other concomitant injuries, so whether it's associated with meniscus injuries or degenerative meniscus tears, ACL involvement, you've got to take that into consideration as well. So it's not just.
So you need a stable knee. Yeah, that's right. So you need a well-aligned, stable knee. To be able to do any cartilage restoration, you need a well-aligned, stable knee. So that's what you're telling me now. Okay.
And then patient factors. So, I mean, he's 30 young, but is he a patient that's sitting on the couch playing computer games? Is he an active guy that's running around, playing sports or sportsman?
What is better, someone that sits on the couch or someone that runs around?
Yeah, take it like a trick question, but I'll probably better to sitting on a couch.
Yeah, I think so. You know, for your repair, they probably have a better outcome if they don't load it as much. But obviously, you don't want someone that is diabetic or like smoking or have a poor hearing response. Okay, cool. So, what would you be able to offer this patient now? What technique in your South African?
Our technique is in our setting is the microfracturing and bone marrow stimulation to create a fibrocartilaginous cap. So, I mean, that's what we do. But generally, the size-wise, so you need to generally less than 2 centimeters squared would be the ideal defect for that.
That's right. What if the defect is bigger?
Neither you got to consider like an osteochondral autograft transfer. So an autograft,
Okay.
Take it, and then you got the options that we spoke about earlier is the ACRs, the autograft chondrocyte implantations. But I've never seen
so you could tell them, look here, you can also fly to Europe and then just pay someone 100K or 150K, and we do that. You can do the ACI or MACI.
Yeah.
Okay.
Yeah.
But what you can do here now is a microfracture. You could maybe even put if you wanted, the patient you got consent to open up the knee, you could even think about putting a little periosteal patch on it. We do have availability of some matrix that you can plug onto the defect, but you have to clean this defect up all the way down to the tide mark, through the tide mark. You have to have stable rim around this defect so that any kind of scar tissue can adhere to stable meniscal, stable cartilage tissue. And then you have to basically create some form of clot there. So that's one option. That's the stimulation technique. Or you can do a replacement of, take out cartilage somewhere in the knee and then plug it back in there. Cool. So that's basically, you've done very well. This is what we've discussed. So you want to make sure that this is aligned. You want to make sure it's stable. Then we've chatted about these lesion sizes and what options we have here. So this was probably a lesion that's around 2 to 4 centimeters square. So here we would probably go for an OAT. And that's basically the outcome. Remember, OAT in South Africa is usually indicated, well, the insurances will only pay for someone that's young, 35 or younger, someone that doesn't have arthritis, someone that has a stable knee that's well aligned without osteoarthritis. And so then you can motivate to do an OAT in private, and in state. That's basically what we would do. And here, these are some of the outcomes. So what is microfracture? So what if we compare microfracture versus OAT? That's what the patient is going to ask you. Soccer player comes to you, has this defect, and I'll say, hey, what is better? Should I do microfracture or should I do OAT? So you say to them, look here, in 5 years is similar, but after 5 years, you're going to have more longevity with a OAT. After 5 years, most microfractures will give you trouble. So the OAT maintains a better outcome for longer, and you can return to it quicker. So to activities in 6 months, you're back playing soccer, provided there's no other injuries in the knee, compared to a microfracture where it takes a bit longer, 9 months. And you're replacing like with OAT, whereas with a microfracture you've got a cartilage, scar cartilage. So all in all, it's ideal. The OAT is ideal for a young, active male patient that wants to go back quick and basically do activities for longer. But it's a bigger procedure. You've got donor side mobility, clicking and locking around the patellofemoral joint where you harvest it, and you have you need to make a small cut to be able to see what you're doing. And so there is a little bit more mobility, initially mobility involved compared to the microfracture. Cool. Now, microfractures versus ACI. So let's say you send this patient to Europe and say to him, here, pay 150,000 Rand or 200,000 Rand. That's besides all the flights and hotels, or go to India and do this. And then you have to tell him at 2 years, no difference in your life quality. No difference in your ICRS, adrenal or biopsy, and no difference in treatment failure. So at the moment, randomized controlled trials are very few, and there's not a huge difference. But I tell you, when you look at the cartilage after an ACI, it looks very much the same as the cartilage that is healthy, and almost even shinier and better. But it's obviously subjective from a few cases that I've seen. It is amazing to really feel the cartilage feeling very, very similar, but apparently it doesn't translate in these bigger studies yet. There's a huge push from the industry and obviously from the research kind of groups to figure this out, and therefore you get often patients are quite keen to have this done, but unfortunately, no big data yet that says that one is better than the other. And then the outcomes, microfracture versus ACI. The microfracture has got, on histology, it's not as good as the OAT. The OAT is closest to hiding cartilage, like we say. And between these different techniques, there's no major differences in certain research scores that they have. The ACI has got most complications, and oftentimes what it actually does is the graft or the bed of the cartilage defect starts to grow too much, and you get hypertrophy, which has become better with the matrix, but it's still an issue. Is that all of a sudden you're creating a little bit of a bump there that people feel is almost like walking on a shoe, on a stone in your shoe. Yeah, so that's that. And then allograft, I don't think we need to really speak about allograft. There's this group around Bagby, which they are in San Diego, that have got a massive experience. And I think if you have the availability of fresh allograft, you need to almost have your own kind of center of excellence that treats them, to be able to organize this whole thing and to have the quality of the graft is actually the important part here. The technique is also important, and how to harvest it and how to implant it. And there's special workstations that you need to create the perfect plug. But in the end, it's all dependent on the cartilage quality, and that's dependent on how fresh it is. And so you have to actually create a system of a perfect harvests and workup of the donor, and to have the recipient right there to be able to really have good outcome. Okay, cool, guys. I think let's leave it at this. Is there any more questions you have?
Hi, Prof. It's Hruni speaking. I just
Yeah.
want to ask you, I just have 4 questions. I wanted to know, you showed that with the meniscal repairs, that augmenting it with tibial tunnels, or I almost want to say doing that fancier repair with the transtibial tunnels instead of an all-in way. I just wanted to know, how does that influence time in the OR? And what did I want to ask you as well? In your hands, is it something with a more steeper learning curve? That was my first question. And then I just want to comment, it was very interesting to see that the Americans were the only group, the AAOS group, that pushed, when you looked at that on that table that you posted, osteoarthritis was basically their only indication, that they said, we're not going to do debridement for the meniscus, but for all of the rest of the categories, they actually pushed surgery. And it just shows that they want to put the money back in the pockets of the surgeons almost. And then I also wanted to know, if the meniscal transplants, I assume it's an open procedure. I just want to know, what is the infection rates after that? And is there some sort of anti-failure therapy that we need to give to the patients to increase the success rate of that, due to the fact that we're using allograft? And I think that was basically what I wanted to know.
Okay, cool. So let's start first with the transtibial techniques, or the tunnel techniques for the meniscal sutures. It's almost like a half of an ACL, because you have to put the AMA in, you have to find a correct spot, you have to drill into that area where you want to suture, and then you have to fiddle through the passing suture, and then somehow grab that meniscus with a meniscal scorpion that you also similar to the shoulder, like a scorpion that pushes through your suture tape. So it's fiddly, but I think after a while you can it's not too complicated. The meniscal roots are in the back of the knee, but it's possible to with a few tricks to actually get good access there. and it's definitely worth the time that you invest. There are other techniques to actually repair it. For example, people use fast fixed anchors and try to put them into the stump of the meniscus suture, and it is possible to do that, but it's not as biomechanically, it's not as good of a repair. So yes, it takes longer, it is more expensive, a lot more expensive than a normal meniscus suture, but it's worth in the long run to protect the compartment from osteoarthritis. I guess we could, I'll show you after in the next minute, in our next cadaver workshop, we'll do one. And then the next question was, yeah, you're right. It depends on who sits on these committees that determines whether this is a good thing or not, and how vocal these members are. It does obviously create bias. So these are all, and that's why I've got the slide here for you. These are all orthopedic surgeons that are promoting not just a patient, ethical patient management, but also want to obviously not upset their colleagues too much. So I think they just try to find a good middle way to not upset the one, but also be ethical with the other. And it turns out actually that besides these, I guess, the broader you make these studies, the less you can actually prove that they make a big difference. You know, the same happened in the shoulder. Almost no shoulder surgery makes a huge difference in the life, in the outcomes if you make them big enough. So I think a good middle way would be to really give the patient the time to cope non-surgically, and then if they don't have arthritis, to say, I'm going to offer you this, but we have to manage our expectations together. So my expectations and your expectations must be the same. Otherwise, you have an unhappy patient. It's not worth operating on someone that doesn't understand or doesn't want to accept that you can't make their knee new again. And these are just, this is a nice slide because it shows you, and I tell you, in a knee practice, I would say 50 to 60% of your day-to-day interaction with patients will be based on this. It'll be patients coming with knee pain that are older but not ready yet for arthroplasty. And to then really hold back and not jump the gun is very important for your longevity of your practice, because you don't have happy patients, and your referral base is also not happy with you if you just jump on all these meniscus surgeries. Then the last question you had, I can't answer you because I don't have much experience with allografts. I can't answer you what the tissue reaction is of the allograft. Normally there shouldn't be any massive tissue reaction because it's avascular and it doesn't really have a huge amount of it doesn't trigger a huge amount of a host response, but I don't know. I don't know, and I'd have to read up on that. And certainly the infectious rates are higher than in your own tissue. They are starting to use hamstring tendons and shaping the hamstring tendons into a meniscus shape, and then implanting those hamstring tendons as a meniscal autograft. But the difference between that and the allograft in terms of infection rates, I don't know. So my gut would say, yes, there's definitely a high infection rate because it's big surgery, it's open, you know, oftentimes, I mean, larger cuts and longer surgery. And it is an area that doesn't have a lot of vasculature, so assumably the infection rates are high, but I can't give you a proper number on that. Any other questions? No. Okay, guys. 10 to 10. Let's call it a night.
No, thanks.
Is Dane still around?
I'm here.
Okay. Can I ask you, so whose account is this? Is this Maritz's account?
Yes.
Okay, so that's why it didn't cut off at 40 minutes.
Yeah, I think he pays.
Okay, cool. Perfect. Well, thanks, guys. Thanks for organizing it. And thanks for all being there until so late. I hope it worked out for you. And I hope you learned a little bit of a few things that you can use in your exam. And hopefully also when you start becoming a big-time knee surgeon somewhere, just don't cut all these poor old 60, 70-year-olds with meniscus tear. Don't just give it some time.
Just cut their skin and have the same outcome, right?
Exactly, yeah.
Yeah. I'm opening a
Thank you,
sham
Prof.
surgery.
At least now, Ahmad, you
Thanks,
know,
bro.
eh? Ahmad, you know now. This is like, you know, the England Journal of Medicine, 2013. Okay, cool. All right, guys. Thanks very much.
Thanks,
Prof.
Interesting.
Bye.